Thank you, Kesley.
Yeah, so having already done the acknowledgement of country and the acknowledgement of lived experience, I would like to just say that this webinar is hosted by the Oceania Mental Health Advisory Committee, which is a committee of many people across the Pacific region who are working together to look at how we can support each other, how we can be good neighbours, and to assist in mental health reforms. The work of the Oceania Mental Health Advisory Committee and its members is an amazing effort. We're all doing it in our spare time, if you can imagine we have spare time. And so pulling this webinar together is another one of those fantastic achievements. So thank you and welcome to this awesome webinar. I hope you look forward to the amazing discussions that we have from our presenters today.
Thank you, Julie. And before we start the session today, I wondered if those of you who could put your cameras on. I'd like to, if you're up to it, like to take a snapshot of the screens. I think it's always fabulous to see who's online. I can see a few friends, Rami Lord, and a few others online. And if you can all put your cameras on, I'll have to do it twice because there's so many of us online, I'll have to flick through. Excellent. Thank you so much. That's great. More and more people. Ah, that's great. Wonderful to see you all. Okay, now big smiles, everyone. And I will take it now. Okay, that's fabulous. I've got that one. Hang on a minute. It takes me a minute to do this. Sorry for the just two minutes more, because I'd just like to go to the other screen where the other colleagues are. So although you don't know which screen you're on, there's a few more there. If you'd like to just smile again, and we'll try and capture the second screen. Smiling, everyone. Excellent. And I'm taking now. Thank you very much. That's really lovely. It is with great honor that I'd like to introduce our first speaker. Colin, it's a real pleasure to have you online with us today. I know you and I've worked together for many years, and I really am very excited and honoured to hear that you got your knighthood last year, and the last of the Queen's birthday before the King came in, and you're now Sir Colin, and that's a great honour for all of us. We know that you work tirelessly across the region and have done for many years. I know you're an associate a professor now for Pacific at Auckland University, but you've had a significant history across the region, including working with the Pacific community as a Director General for many years, working with many industry, public and NGOs, including being on many of WHO's strategic thinking and working groups. I think today we're really excited to hear about the AMFAT study, from the Ministry of, I'm forgetting from New Zealand, and the MFAT work that you're about to go forward on. So thank you so much again. I'll open the floor to you to share your slides.
Thank you very much, Michelle, for inviting me. It's a pleasure to be here. I'm just checking the you can
see it well.
Okay.
See it well.
Okay. So thanks very much for the opportunity to share some thoughts with you all. I thought I would do a brief orientation, if you like, the global burden of disease due to mental disorders, and then speak a little about the Pacific. And I thought I'd also speak a little bit about the Pacific people in New Zealand, because the connections and the findings are related, and one informs the other. And then as Michelle said, I want to spend a little time on the study that the New Zealand Ministry of Foreign Affairs and Trade is funding us at the University of Auckland to do in 6 only Polynesian countries at this stage. A brief reminder, it's mental disorders is a significant cause of suboptimum health, and the estimates are that it contributes 15% of life lost. In other words, it's a significant cause of poor health. Mental disorders and substance abuse are the leading causes of non-fatal burden, depression and anxiety being high on that list. And you will have seen many reports from around the world, net effect of COVID-19 has had on people, not just in the islands, but around the world. Self-inflicted injury, suicide, a major cause of leading cause of death for young women around the world. And depression and anxiety in dollar terms is a significant cost to global economies, the estimates being $1 trillion. This is according to WHO. And of course, there are ongoing concerns about human rights violations, about stigma, about discrimination around the world. And those of you from the Pacific would know that this is indeed a major problem in many of our islands. And the other thing to say, of course, that people with mental disorders, even though we know that we can treat a lot of these conditions at relatively low cost, people aren't getting the treatment. So in other words, whilst there's significant morbidity associated with mental disorders, and we know how to treat many of these conditions, people are not getting the treatment that they need. So that's a kind of a general statement on the situation around the world. In the Pacific, I suppose my main concern is the fact that we actually don't have a good enough handle on the prevalence of mental disorders. I mean, everyone has a story, of course, and particularly post-COVID, everyone talks about rising incidence of mental disorders. But actually, I think this is an indictment on all of us after all these years of commenting about mental disorders. We don't actually have a good enough description of the prevalence of mental disorders. So the figures that you see being thrown around are estimates. In fact, WHO use projections and estimates from elsewhere in the world to try to say, well, it's like this or like that in the Pacific Islands. The reality is we don't have good enough information, which is part of the reason why we have convinced the New Zealand Ministry of Foreign Affairs and Trade to make a start on trying to at least improve the knowledge for Polynesian countries. We do know, and there's reasonably good estimates of the high rates of mental disorders around the island in the region, in the Pacific. But like the comment I made with regard to the global situation, the same situation applies: low access, low use of services. I think it's important to just remind us all that mental disorders are as much a medical diagnosis as a cultural phenomenon. In other words, it's not that straightforward to try to measure these things. So, for example, hearing voices in medical terms, people would say, if you hear someone is hearing voices, you'd say, well, you know, they have schizophrenia. But, you know, of many of us who are of the Pacific will know that people generally remain connected to their ancestors, to their families, and can talk, not so much in vocal terms, but remain connected to their families who have passed on. As I said earlier, stigma is a major concern, and we know that family, and even in New Zealand, whānau would tend to hide the person with mental illness away so that there's no embarrassment to the family. People often believe that it's a possession, some description, and many families rely on traditional treatments and family support for someone who's got a mental illness. And obviously it's important to acknowledge the fact that many in the church community also offer that support. There was an estimate, I know the title of this was Workforce in the Region. There was an estimate by Fiona Charlson and others and published that actually, based on burden of disease data, they estimated a 74% increase in disability related burden of mental disorders between 2010 and 2050. In other words, significant. I haven't seen anything else. And I know that that estimate is somewhat dated, but they say that the workforce demands for Smile Island states will increase correspondingly as a result of the increase in burden of mental disorders. I don't think I'd be speaking out of turn if I say that legislation, mental health legislation, in some islands is outdated. So we have things like suicide and homosexuality still regarded as criminal activities. And indeed, there's a chronic shortage of trained mental health workers. By this, I mean medical, nursing, and so on. And often someone who has a particularly severe, serious mental disorder will often come to health services referred because they've done some, what's the word? It caused someone some harm or done some damage, in which case the police would pick them up and refer them to the health service. I was involved, this is how old I am. I was involved in the first national mental health epidemiological mental health survey in New Zealand, 2003-04. This is still the gold standard. I know people criticize some aspects of it, but it's the best study that I know of with an oversample of Pacific people in New Zealand. And these are the findings from that study. Pacific people experience higher mental disorders than other Kiwis. About half the population over the course of their lifetime will report a mental disorder. About 6% experience a serious mental illness in the past 12 months. It's actually not that different from other New Zealanders. But again, of concern, of course, only half of those with a serious disorder had access to services. And some people say that things are improving in New Zealand in terms of access to services, but I have my doubts. The important finding from that study is that if you were born in the islands and you migrated to New Zealand after 18 years, you appear to be protected from mental disorders. In other words, the New Zealand environment is not good for you, I think, if you're a Pacific person. That's still a finding that some people question, but it does have a biological, socially plausible Roger Mulder and others updated this in 2004. This is their paper, where they said that the 12-month prevalence of mental disorders was similar between Pacific people and European New Zealanders in 2004. Pacific folk report higher prevalence of psychological distress, but actually lower levels of psychiatric disorders. More Pacific people abstain from drinking alcohol, but the small group that do drink for the rest of us, and a lot of harm is done by. So about half the Pacific population in New Zealand don't drink alcohol at all, particularly women. But there's a small group of Pacific folk who consume alcohol to very high hazardous levels. And I still think it's one of our biggest problems that continue to go uncontrolled. Similar prevalence of serious mental disorders, but again, low use of services. Although Roger and his team seem to think that access to secondary care services was improving. I'd like to believe that. The Health Promotion Agency now discontinued in New Zealand off of the mental health monitor and health and lifestyle surveys, repeated pretty much what we knew: higher prevalence of psychosocial distress and depression compared with other New Zealanders. Stigma remains problematic, harmful use of alcohol, and people are not as well informed about services and struggle to get access to the care they need. And the other interesting finding here is that if you're from Cook's Niue and Tokelau, you tend to be at a particular risk, this is not unusual, because the loss of language and the loss of cultural connectedness and social connectedness in New Zealand appear to be particularly prominent if you have a New Zealand passport. So the study, very briefly, the New Zealand Ministry of Foreign Affairs and Trade has funded us being the University of Auckland, our centre, plus others who are. I'm not a mental health expert, so we're relying on advice from other Pacific folk who are trained in mental health. They're funding us to do a study in 6 Polynesian countries. We started in Samoa earlier this year. So the data collection has been completed, and colleagues are writing up the report as we speak. And Tomo's next, the team are in Nuku'alofa this week, training the interviewers. Tuvalu and Tokelau on the planning stage, and we've just been invited to go to stage 2 by the Health Research Council, which means that we have a above average probability of getting HRC funding to complete the study in Cooks and Niue. The study is in 2 parts. One is a basic epidemiological study of the prevalence of common mental disorders, and as a result of those studies, co-design with local leaders, communities, and mental health workers, and appropriate responses. For example, modernizing legislation, clarifying training and workforce needs, service access, those kinds of things I expect will come to the fore. And so I suppose from my point of view, it's not good enough to just do an interesting academic epidemiological survey and not try to respond. So that's the very briefly what we're trying to achieve. I think it's also important to say that these studies have to be driven locally, led and driven locally, and they decide what is released, not us. We're helping them out. Sorry, I'm running out of time, Michelle. Oops. And just to finish off, I'm happy to talk more about the study, but at this stage, there's really no results to share. It's just to tell you that what's happening in, at least in Polynesia, and also to say it's not going to answer all your questions about mental health and well-being in Polynesians. In other words, we don't have the money to do a large sample to pick up less common disorders. So it'll tell us some things, but it won't tell us all of the things that you ever wanted to know. So just to finish off, I think in the region, in the small islands of the region, there is an urgent need for better data and information on the prevalence of mental disorders, including aspects of what could be protective factors, cultural context, service needs, and so on. I think there's a real need to improve access to mental health services across the board, increased investment in the mental health workforce, in treatment and support services, mental health services in the region. Clearly the poorer second cousin of services. I think there's still a lot of education to be had in the public about the mystery of mental illness, to try to destigmatize and demystify mental illness, enhance public information and awareness about mental illness. As I said earlier, I think there's a need to update and modernize health legislation and address existing anomalies. I also think there's a real need for ongoing training support for mental health workers, including ongoing professional development. Thank you very much.
Excellent. Thank you so much, Colin. That we're so excited about this study. I mean, it's so needed across the region, as you know, and I think it's really important. A couple of questions. I know that you can't stay with us till the end. A couple of questions have come in already. And one was for me, well, could you just give everyone a little bit of an outline on the timeline of the study? When are you hoping to get the sort of final data, so we've got some in our heads when to look out for the study? Another of the questions has come up asking around, are you covering any of the leadership aspects of mental health in the study? And I think that is a big need across the region. And finally, a setter asked, and I think that this was in relation to some of the previous work you talked about, were there any ethical sort of outlines or ethnicity for the previous studies that were carried out in New Zealand? I mean, I think that's a very old study, because I think you said that was 2003, 2004, but I think it was just, was that original study balanced with Pacifica in New Zealand? Did it give some outline for those? Just those three questions. Thank you, Colin.
Yeah, thanks very much. I know you don't have a lot of time on timelines. We've completed some, and they're cleaning the data and doing the analysis and writing the report as we speak. The training of interviewers in Tonga is happening this week, and we expect to have the data collected before the end of the year and the analysis to commence. We've just started planning with Tokelau and Tuvalu. I expect that we would be out in the field early in 24, and we will have the data there for June of 24, by June of 24. And Tokelau and Niue is still subject to HRC funding, but assuming all goes well, that would be second half of 2024. And so I expect Christmas 24 will have quite a lot of information available, not all of it. On leadership, absolutely a critical part of the study, and particularly leadership by local folk to determine the shape. I should also say that we have adopted a practice of obtaining ethical approval from the University of Auckland Ethics Committee, but also getting local ethics approval. So in Samoa, we had to get ethics committee approval there, and the same in Tonga, and the same in other places. I'm not sure I
and that always takes so much time, doesn't it? You know, it's so important getting those different bits of ethics, but
it's important. It does take time, but it's an important part, particularly for mental health studies, because as you heard me speak a little about the fine balance between cultural interpretations and medical interpretations. You do need to subject your plans to an external credible body for comment. I didn't quite get the third question, but we did, a number of us Pacific were part of the big New Zealand study, and we had to obtain ethics committee approval. It
wasn't around ethics, it was around ethnicity specific. So it was around how that original study divided up. Did it explain sort of different groups, and were there any trends in different Pacific groups across New Zealand? I think
I know we oversampled Pacific, and we had something like 2,500 people in the sample, which would lend itself to some sub-analysis of at least, you know, the bigger communities, Samoa, Tonga, Cooks, for example. But I don't know that we ever wrote it up in that way. It may be something to think about. So we tended to just treat the group as a whole.
Okay. I'm very aware of time, and really grateful to have you with us, Sir Colin. And I think just having your ongoing, views in this world, and really look forward to the study's findings in early 2025. And good luck with collecting all that data over the next year. Thank you so much. Thank you. I'd now like to go to our next speaker, and I'd like to invite Jasmine. Are you there, Jasmine, ready with your presentation? So Jasmine Nivalakora is an educator and artist who's based in Samoa. I can't see the presentation coming up yet. See if you can share it, Jasmine. And you're currently the curator of Global Shapers in the APIA Hub. Well, there you are, Jasmine. I can see that you're online. Can you share your presentation? Ah, there you go. Excellent. That's wonderful. And I think this Global Shapers APIA Hub is a dynamic group of young Samoans, and really look forward to hearing what you're doing in Samoa. It sounds wonderful. Over to you, Jasmine. Thank you. Can't hear you, Jasmine. There we go. You can hear you again now. That's it. Over to you. Off you go. Excellent.
Thank you. Thank you. All right. Just going to double check if everyone can see my presentation slide.
We can see it well.
Thank you. All right. As I was saying, thank you very much for the opportunity to be part of this very awesome conference. Certainly very important for our part of the world. And I'm based here in APIA, Samoa. And I am the curator of the Global Shapers APIA Hub. Just a little bit of info about who we are. We are a syndicate of the World Economic Forum's Global Shapers community. We are young professionals between the ages of 18 and 30, and we work in all different areas, basically to promote equity and economic development globally. Now, just a little note on my presentation. This is a non-clinical perspective on the challenges that are faced by the target demographic that I work with, not only as an educator, but also as the curator of the Global Shapers, a peer hub. This is a study that we are hoping to do in our country over the next few years. All right, so I've got 4 key things that I will just very quickly go over. I will give you a brief intro of Samoa. Secondly, I'd like to talk about some key issues that impact the mental health of young people in Samoa, as well as some of the youth perspectives surrounding these. I understand that there is still not a lot of literature that covers this particular area, especially for Samoa. I'd also like to very quickly look at a few ways forward that our organization is looking at encouraging in the communities, just before I get to my conclusion. All right, so Samoa in brief, presently we have a growing youthful population. For me as an educator, when I look at the phrase youthful population, the first thing I think about is the literacy rates. Now, not a lot of people around the world probably know this, but Samoa has got very, very high literacy rates. In fact, the literacy rates of both males and females are very high. There's not much difference, and this is data that I have extracted from the World Bank's gender data portal. It is quite recent. It's from the year 2021. So Samoa is doing well, I would say. But also we do have challenges. Now, what really inspired and interested me to begin with regards to mental health in Samoa is a documentary that I saw as a teenager. It was filmed, I believe, in the year 1983, and it was not about mental health. It was actually about immigration. There was this scene on a beach, very nice, beautiful, tropical beach, what Samoa and much of the Pacific is famous for. And the commentator said quite handedly, beneath the lush beauty of this country is the world's highest youth suicide rate, double that of Switzerland. Samoa has a very small population, and I was in Switzerland a couple of months ago, and compared to Switzerland and all of Europe as well, Samoa is very little, and I was quite interested. It's a beautiful island. It's anyone who knows anything about Samoa will know that it's a very Christian country per se. So I was wondering, why is it that our suicide rates are so high? And that, of course, led me to do a bit of research on it. Recent statistics will tell you that Samoa is actually still ranked in the top 50 in terms of the world's highest overall suicide rates. We are at number 39 at the moment. So that's an average of 12.6 per 100,000 people. Interestingly, the majority of deaths by suicide in Samoa are still youth. So this is not much of a change from 1983 or the early the early post-independence years, sorry. Now the age range is very interesting. Majority of suicides in Samoa fall between the age brackets of 14 and 35 approximately, and the majority of deaths by suicide in Samoa are actually young males. Now, this is a lot of quantitative and statistical data, which I love, but in my work as an educator, what I also like to do is to see how I can really humanize these figures. I look at two focused questions. First of all, who are these people? And secondly, what exactly is happening to them? Youth suicide in Samoa is very close to my heart, not only because I am Samoan, but also because I lost my brother to suicide in the year 2014. He was 19 years old, and I imagine that his death is just another statistic on one of these websites. But it affected me and it affected our family greatly. So I'm really, really interested in unpacking the who and the why in my country. In terms of the why, the first thing that I've discovered is that employment stability is one of the major causes of stress and one of the main things that impacts mental health in Samoa. I like to think about employment-related issues pertaining to young people as being 4 waves. I like to use the wave analogy because it is a very Pacifica imagery. So firstly, we have secondary school students. As an educator, I encounter everyday students from different social and economic backgrounds, some of whom at 14, 15 years old are already thinking about how they can contribute to the family finances. I have had over the last few years many students who've come to see me about letters of referral, even to help them fill out job application forms. And it's very difficult to explain to them that you are only 14 or 15 years old. You can't yet find the kind of employment that would provide for your family, but they're thinking about this because they already feel the pressure that their parents feel under the weight of a third world developing economy, but also an economy that was greatly impacted by the COVID-19 pandemic of the last few years. The second group of people who face a lot of stress and whose mental health is greatly impacted by employment instability, I should say, is some new tertiary graduates. We've got the 2 main universities in Samoa, that's NUS, or the National University of Samoa, as well as the regional one, USP, University of the South Pacific, and also other small tertiary providers like APTC and so forth. In the Samoan, I think this might be a similar sentiment in other parts of the Pacific, but as soon as you graduate, especially if you're getting a degree, there is this very high level of expectation on you because you are now qualified. The thinking that often is that you should go and get a job, and it's now time for you to become one of the economically active members of the family. And this pressure is particularly high if you are living in an extended family situation, or ainga potopota as we call it in Samoa. A lot of Samoans still live in extended families. So when you do live in an extended family, the idea is that you will help to provide for basically everyone, whether it's 10 people or 15 or 20 or 25. Wave 3, first time or new employees. So let's say the tertiary graduate does find a job. They will then be worried about how well am I doing at this job? Am I keeping up with my peers? But also, how am I going to support my family and extended family's expectations on a starting salary? You'll still find that some of our parents in Samoa do not want to hear about this phrase, starting salary. Or the idea that you're very well qualified tertiary graduate is going to go in on a starting salary, which is basically the lowest salary that the organization has to offer. Number 4, young professionals. So even if you do survive that first wave in the workforce, there's the stress and the anxiety that comes with worrying about maintaining the job, advancing the career. There's the competition for overseas scholarships in Samoa. One of the only ways for a young person to go overseas and get what's still considered a good education is to get a scholarship to either Australia, New Zealand, Fiji, China, Japan, or if they're very lucky, the UK. And so there is all this pressure around basically every stage of a person's working life, even pre-working life in Samoa. Another thing that greatly affects youth mental health in Samoa is educational stability. Now, as I said earlier, the literacy rates in Samoa for both males and females, very high at the moment. However, these are just statistics, and there are also a lot of issues that are being faced by our young school-aged population, as I would say. I've decided to do this section as like a brainstorm. I am an English teacher and I do a lot of brainstorming activities with my English classes, but I was thinking about this phrase brainstorm. high school is a very stormy period in the lives of many young people, as is the first year or two of undergrad at university. So I've put here some of the common things that you will hear when you ask young people in Samoa, what is affecting your mental health? What causes you to be anxious? What makes you sad? So questions like, am I studying subjects that I actually enjoy, or am I just here to make my parents happy? Also, again, related to financial issues and financial stress, what will happen if my parents cannot pay my school fees this term? Another one, and this is a very, I think, cultural one. What will happen to me if I don't get good grades this year? Will I get a hiding? Now, corporal punishment is illegal in Samoa. The bill has been passed. However, it continues to be in a lot of families because of our culture. So that is something that we're still struggling with. I like to think that we're slowly but surely getting to a place where it's not an issue for us anymore, but it definitely is something that's still there. And it causes a great deal of anxiety and depression in a lot of young people. Another question that students might ask, or something they would say that's affecting their mental health, is things like, will I get left behind if I spend more time studying and less time with my friends? Or are my friends secretly making fun of me when I give incorrect answers in class? Now, what I found is that sometimes we look at these as very insignificant questions. The advice that we give them as educators is often, you'll grow out of it, or in the next 5 to 10 years, it won't matter so much. What I've realized recently is that it does matter. For a 16 or a 17-year-old, being left behind and not being part of a social group is probably the worst thing that can ever happen to them. And it causes a lot of stress, a lot of depression, a lot of anxiety. And this contributes to our continually high suicide rates. But I also believe that the mentality that still exists of it's not important, you'll be over it in the next 5 years, that is also another contributing factor. Something else that affects the mental health of young people in Samoa, social and cultural obligations. And I know a lot of my Pacific colleagues who are on this call will understand exactly what I am saying here. This is an example of a Samoan extended family. That's my extended family. There's 108 of us in total, direct descendants of my grandparents. And when we have in Samoa what we call fa'alavelave, so that's a funeral, a wedding, a birthday, or a title bestowment, there is a lot of pressure placed on those who have jobs, especially younger members of the family. One of my favorite Pacifica authors, Sia Fidel, said, and I'm paraphrasing here, but in Samoa, there is no I. It is always we. In Samoa, there is no I. It is always we. In Polynesia, we have a very, I would say, communal mentality, which is great, except for the fact that now, as globalization increases and our young people become exposed to all sorts of different trends and knowledge and information, people are starting to move away from this communal we and really question, who am I? Apart from the, we, the collective, the community, the Ainga Potopoto, who am I as me? So some questions that we often ask, am I selfish for wanting to resign from this job or move overseas instead of working to support my family? What if I have religious, social, and political values that differ from the ones I was brought up with? If I have to be a caregiver for an elderly or disabled relative, do I have to put my whole life on hold? And also just, what should I base my identity and sense of self upon? My family connections or my own beliefs? And this is a very stressful, I would say, experience for a lot of young people. If you already have clinical anxiety like I do, you can imagine that it's probably 20 to 40 times worse than if you don't. But these are questions that we are faced with as young professionals and as young people in Samoa. And oftentimes we don't have anyone with whom we can share because it's seen as, you know, disrespectful in our cultural context. Now, we talk about, there's this lovely saying in Samoan, we say, "E telea o tangata na iloa o la au umalava," meaning one person has more roots than any tree in the world. Our roots run deep, and the roots are our extended family and our cultural connections. Another important question I like to ask is, what happens when those roots and when that tree is digitized? What happens when the tree becomes digitized? As I said, globalization, I often say to my students, you are the TikTok generation and we were the Facebook generation. Brings me to the next issue that affects, and I recently found that this contributes greatly to the high suicide rates in Samoa, interpersonal and relational issues. We have a Samoan saying.
Jasmine, we're beginning to run out of time. This is so interesting. I don't want to shorten you, but I'm just wondering if you can speed up a little bit. Thank you.
All right, thank you. We have a Samoan saying, "Te uleva." The word "va" means space. So I think about te uleva versus cyberspace. And the final issue I want to talk about, which has caused a lot of suicides in Samoa in recent years, is the use of social media to defame and to bully. And this is especially true for the younger generation. I have up on the screen, and I hope you can see, these are some of the defamatory social media pages that exist in Samoa. I'm not sure if the rest of the Pacific has its syndicates of these. So I had some ways forward, but basically we need more access to mental health services and providers in Samoa. We also need these to be affordable, to provide confidential service to anyone who needs it, and also to be able to answer questions from people of diverse gender and sexual orientations. Also, in terms of employment stability, more career advisory and planning services, educational stability. What we're pushing for in our project is some increased scholarship and sponsorship schemes, and to also encourage young people to go through the local education systems. Also, in terms of social and cultural obligations, encouraging open and honest communication within families, and also just more empathy. It's difficult in our cultural context, but definitely something that we'd like to encourage. Same thing with interpersonal and personal relationships, open communication within families and also within communities. Brings me to the end of my presentation. Thank you very much for your time, and we hope to see more progress, not only in Oceania, but also in terms of the rest of the world. Thank you.
Thank you, Jessica. I think that was really a very, very excellent presentation and gave us a really good background into some of the cultural norms. I think it's fascinating that our young people are maybe swinging more towards individualistic cultures within their collectivist paradigms at the moment in the Pacific. So very, very complex. And I hope everyone's got some good questions at the end for the panel. So thank you, Jasmine. That was excellent. Could you mute yourself, Jasmine?
Okay,
Will you'll stay on? So Jasmine, we'll keep you on for the panel at the
tomorrow.
end.
Yeah.
Excellent. Thank you. I'd now like to introduce our next speaker. So Millie, I hope you can start to share your presentation while I introduce you.
Noted, Madam Michelle.
Excellent. Thank you so much. And Millie is a director of nursing at St Giles Psychiatric Hospital in Fiji. But I can see you've had many roles in Fiji, including being a lecturer at the Fiji National University. So it's a real pleasure to have you here to discuss some of the reimagining mental health and nursing workforce in Fiji. Over to you, Millie. Thank you so much.
Thank you, Madam Michelle. Good morning, good afternoon, and good evening to the other parts of the world that are listening for today. I would like to take this time. I believe that Madam Michelle has already introduced me. This is the first presentation in terms of the slide. This is our conference room from St. Giles, where I'm sitting, presenting it from today with my Madam Deputy Director of Nursing and my 8 unit managers, and some are listening from their own gadgets. I would like to acknowledge this time Madam Michelle for Dr. Gil Cheng. I believe that she identified my name to be part of this presentation. Also with the Oceania Mental Health Advisory Committee, the working committee for the webinar, that is Madam Julie and yourself, Madam Michelle, and the other colleagues that are here, the management and the staff of St. Giles Hospital. Also would like to acknowledge Mr. Naindiri, who was the former chief nurse and also the former director of the Nursing Council, who has been assisting us, being the mentor for this national nursing workforce crisis response or mitigation. And also to the nursing stakeholders, maybe they are listening with us for today. Well, my presentation this morning, I knew it's 15 minutes. I'm going to be very fast. The first slide, my topic is on, it's been linking to the mental health workforce in the Pacific region, the hurdles and the horizon. So I'm just going to talk about the national, that is linking to the, affecting the mental health nursing workforce at the St. Giles Hospital. This is the first slide. That is the picture of myself on that. I've got a media officer, that is we invited our medical superintendent and one of the senior nurse unit manager, a male, and deputy director of nursing and our former clinical governance manager that has fly over the horizon to Australia. So this is the map on the other side, the hospitals in Fiji. St. Giles Hospital is one of the specialized hospitals that is for mental health. Thank you. Just for the content, number one is the purpose, the background, the introduction, the rationale of this presentation and the strategies in terms of the crisis and the way forward. These are the pictures of the nurses in Fiji, and that is the late Mr. Naindiri. I knew Madam Michelle. Maybe the name is it's well known in terms of she's been visiting Fiji. For the purpose, that's a St. Giles nursing staff. Number one is to share information on the current nursing workforce crisis in Fiji that also affects mental health nursing workforce. And number two is to propose way forward for the proposed strategies to address the nursing workforce crisis. This is just the background, started from the global colleagues that are listening. COVID came in, and that may be one of the instigating factors that allow our nursing workforce to cross over the horizon, even locally and also over the sea of the Pacific Island, to move to Australia and New Zealand. So it created an increase in nursing, leaving the public service better for better remuneration, working condition, and this has been happening everywhere. Fiji is not alone, but we are coming up. It was a crisis for Fiji for the past 2 years. But in terms of in 2014, we have noted that we've got a very significant improvement over the years in terms of the workforce needs. We've got about 4,000 plus. But when it comes down to 2020, 21 to 22, our numbers went down to about 2,000. So with the number of resignation, we've got a high number of resignation from 2022 to 2023, a record of 807. That is in February. Right now, it's more than 1,000. It's about to reach 2,000. Compare with 2021, only 65. So there was a 2.4%. So from us, that is a crisis. So with the National Nursing Workforce Review, this was the last workforce review that was done in 2028 by Ms. Russell. They described some adjustment of the nursing workforce. We need to respond to the increased service demands, and recommendation was there, especially for the salary level of nurses that needs to be increased so that it goes together with the level of training or qualification. But in 2014, this is in terms of our workforce. I'm talking about workforce that is in relation to our topic today. This is the background for Fiji. So for nursing, we have a survey that has been done. They use these tools, the WISN and also the STPST. We managed to get 553 new posts that is endorsed by the cabinet. So that is part of the workforce plan to allow requests for staffing establishment. And it was been approved in that time, 2014 and to 2018. And then in 2017, we have the civil service reform. This was a challenge to answer because majority, especially from nursing, we see that it was unfair because the open merit recruitment selection process came in. We know that reform are coming in, but some we still have to reset in some of the changes, but some are benefit. Job evaluation exercise, and there was a lot of people that lost their job. There was a promotion, a demotion that happened. Recommendation, what we have noted from the nursing side, this is in terms of working together with a professional organization, that is a Fiji Nursing Association. We found that even from the nursing stakeholders, 2008 recommendation, that is a workforce review, this recommendation was not being acknowledged, especially we were coming up with a level of training. So like, for example, your qualification. And then in 2017, until 2022, this is what we have noted, that nurses started to resign from the public health services and joining the private hospital in the country, and also flying over the horizon to Australia, New Zealand, England, and also UK and Canada. So locally, this is the average increase. We try to compare why they fly or they join the other horizons, because there is an increase of 3 to 5K per annum compared with what is in the public hospital. So this is the influx of nurses. So we thought that we need to do something. So this is coming in with the leaving the services, but they place a lot of stress on those who continue to work. I knew this is an international issue, but for Fiji, we are coming up. That's why I'm presenting. I would like to share to the other colleagues that are here. So it's a high demand. You know, when people are leaving, it's a high demand for the appropriate levels of human resource needs to be in the services. So we are in a critical status. So what we should do is that we need to come up with something. Because of the high patients to nurse ratios, currently it's happening here in St. Giles. We result in nurses burnout, dissatisfaction, patients higher experience, with a higher turnover, and also with the incidents that is happening in the institution, also with the general hospital. So with the rationale, we thought that if the resignation is not addressed with urgency now, there will be a severe reversible implication of the Fiji healthcare system. So, and we came up that the nurses are the forefront and we are the majority. This is also been justified by the Honorable Minister or Honorable Minister for Health, that nurses constitute the largest healthcare workforce in the ministry. That is about 65%. So in order for us to deliver the quality healthcare, so relevant numbers, relevant workforce is very important. So with insufficient numbers, so this is what will happen. I knew that you all agree with me that in terms of literature review, it's been there. And also in the clinical, this is what is happening. And we are facing currently in St. Giles Hospital. And this is just one of the things going to lead to increase in nursing over time. This is an example for us. I just bring it back to the mental health services to St. Giles Hospital. For the last overtime financial year, it's about $40,000. And while for July for this financial year, it's $76,500. This is what's going to happen if recruitment or attainment of nurses is not going to be acknowledged by the necessary organization. And we've got a photo of some of, I've been putting up some of the photos. These are some of the examples from the 1, 2, 3, 4, 5, 6. These are my classmates. From all those 6, they have resigned. They left the public health services and they joined the university, they joined the SPCN. They prefer to stay home and do their business in terms of the maybe with the remuneration, with the working condition. This are some of the things. We want these senior people to be on in terms of the clinical leadership, but they prefer to go out. So we are challenged with the evolving population health needs, so it's a burden. And I knew that you all will agree with me on the demand of the human resource and also with the overall health budget that is we currently facing. So the attrition, the immediate remedial intervention and strategies we need to do so that we retain or we hold the high number of resignation and migration that has been happening here in Fiji, including St. Giles Hospital. So these are some of the strategies currently. These are the strategies that we've been doing, Madam Michelle. Number 1, we came up with a submission, a cabinet papers to the nursing state from the nursing stakeholders. Nursing stakeholders, this is including the academic people, even the Christian fellowship nurses, credit union. We've got the retirees, we've got the chief nurse, and our professional association, that is the Fiji Nursing Association. We meet, and we thought that it's time now that we need to make a submission to the Ministry of Health. So it was submitted on the 26th of March this year. There was a formation of a working group at the outcome of this cabinet paper. The Ministry of Health, Head of Human Resource, the Fiji Nursing Association, the Chief Nurse and Midwifery Officer, and the Ministry of Civil Service to look into the nursing issues. So the outcome of this one, during the new budget year, there were some changes, adjusting of the salaries of registered nurses to match the number of years of experience and the expertise, upgrading the salaries of nurses at the entry level, that is the internship, to another level, and the ministry, the government introduced 8% gross salary retention allowance for all cadre of nurses. This is to be part of our retention strategies. They reintroduced the consolidated allowance for nurses, based at nursing station, to acknowledge the specific challenges they are facing, and the efficient recruiting process on vacant position from our side, the nursing, especially from the mental health. I always always push, always monitor and evaluate the recruiting process with the HR in the ministry. Redeployment of nurses through relieving appointment, remuneration of relieving officers. Some of these allowances was being shelved with the previous government. And the introduction of new roles, like for example, nursing assistant and nursing in some health facilities. But for St. Giles Hospital, for those in the mental health facility, their names was being changed. Transition of new type. The nursing assistant was used to call enrolled nurse, and the nursing aide was used to be called as a medical aide. So there is a transition of new title in St. Giles, but the new roles included in other health facility to mitigate the shortage of nurses in Fiji. We also have the improved infrastructure. We've got a minor works, and I believe that the health system is very important in terms of retaining our workforce, especially for nursing staff or nursing officers. Provision of scholarship, awards, and in-service training, either through the Ministry of Civil Service, in-house, and even the Australian government. So for mental health, there is an award being given by the WHO, the Postgrad Diploma in Mental Health Nursing, and Australian government will offer that awards in 2024 onwards. So these are the main people that we are going to work with, the main group, the individual, in terms of negotiating what is best so that we can retain our nurses to solve not to fully solve the horizon, the hurdles, but also to retain them and preventing from moving to the other horizon. So this is the way forward for 2024 to 2026. This is retargeting because this current government will finish in 2026. Just within 6 months in their term, we came up, there is a very, I mean, with the progress, with some of the retention strategies that has been applied to us. We are going to strengthening our working group. Consultation continues for salary adjustment and review some of the allowances that needs to be. Cabinet papers is going to be continued. So we are targeting every year 1 cabinet papers. If it is a maximum of 2, but minimum of 1. And we are going to continue to fight with a good working condition, especially for our infrastructure. And this is how we've got the Minister for Health that is up there. We've got our CNMO, the one with the glass, and we've got that is the President of the Fiji Nursing Association. We've got the Fiji Nursing Association members there, some of the stakeholders, and our own permanent secretary. These are the people that we are going to work with in terms of our way forward. And the last one is the scope of practice for mental health nurses. That is one of the things that we are looking into, and research strengthening. So just the data, I mean, it's more like a narration that I'm talking about, the story of what is happening in here. I just prepared the two tables that needs to maybe just to have some awareness what is happening here in Fiji. In 2014, we were about 4,700 nurses. Right now, compared with this time for this March 2023, it's going down now. It's 2,975 with fill of 2,038. That is the current data that I can provide you for this year, but it's going down with the field, the position. And this is the facility in the Ministry of Health with the term of people that have resigned. Currently, like for example, St. Charles in February, it was 19. So total for this, for the last month, it's about 25 that have resigned. Yeah. Yeah, that is the presentation in terms of the national nursing stakeholders, a national nursing workforce crisis that has been linking to the mental health nursing workforce, Madam Michelle. So thank you.
Thank you so much. Can you stop sharing? Thank you. Yes, such a challenge in Fiji at the moment with your health workforce challenge, and I know that WHO is trying to do a study with your health minister, so hopefully we can get some more data. But really, yeah, really hard. And thank you also for acknowledging Kafakini, our good colleague in Fiji, who did so much significant work. And please, I can see some questions are coming in. So Millie, stay on, because I think many people want to ask you some questions in the panel at the end. But really, thank you so much for sharing that information. Kelsey, I think we're going on to the performance now. Is that correct? The video, yep. And just like to introduce Maya Kayama. She's a Tongan musician, and she's a songwriter and climate activist, and pretty amazing woman, as you'll see now. And some of her work and songs have been around harnessing the power of music to decolonize the mind. So I think very powerful. So over to you to play the music. Thank you.
Once pristine, once untouched, once pure, all of that's no longer there anymore. Stripped down, torn apart, chipped away piece of our hearts, yet still we breathe. Like the wind we still move, like the waves we rise high, like the sun we never die. We will stay standing, hear our calling. We are rooted to the ground, we're here to stay. No staying quiet, we stand united. We are rooted to the ground, can't tear us down. We're here no staying quiet. We stand united. We're rooted to the ground. Can't tear us down. We're here to stay. Thank you.
Well, I think you'd all agree, and certainly the comments, I feel quite emotional following that. It's very powerful. Thank you very much, Moa, and we need to share that song widely. It says it all. Beautiful. I would now like to introduce our next speaker. I'll try and introduce our next speaker following that. Dr. Kalanini, sorry, I can't say your name. How do I say your name properly?
Quinuleti.
Oh, thank you so much. I didn't want to be rude, and I knew I couldn't say it properly. Would you like me to share your slides for you?
Let me just try again and see if I can
no worries.
do it.
You have a very, oh, there we go.
Oh, there you go. It's working.
Excellent. Brilliant. So just go along to the bottom little one and you should get the full screen.
Full screen.
The very right on the, that's it. Press that one.
Right.
Perfect.
Thank you.
Excellent. So you've got a very interesting history and background, and again, a medical practitioner in Samoa who graduated from New Zealand and have over 22 years as a general practitioner, both in New Zealand and Australia. And we really, really look forward to hearing from you. Over to you. Thank you.
Thank you, Michelle. Talofa lava, everybody. So the topic I was given was challenges and opportunities of providing primary healthcare in the Oceania region with a focus on workforce. Since I actually work in Australia at the moment as a GP, I feel that it's not my position to comment on what's happening in the region. But since having worked in the region, I'm assuming that a lot of the things that I'll be discussing or sharing is very similar to what's happening all around the region. Just need to move on to the next. Oh. So I guess primary care, and I mean, I run the risk of reiterating what everybody else knows about primary care. So what is primary care? I mean, primary care, according to the World Health Organization, is a whole of society approach, which, you know, it aims at obviously ensuring the highest possible level of health and well-being that's equitable across the whole populations of whichever country we come from. And also, you know, you try and get in there as early as you possibly can along the continuum from health promotion through to disease prevention, through to treatment, rehabilitation, palliative care, and to try and deliver these as close as we possibly can to everybody's everyday environment. In Australia, the definition for primary care is basically, you know, it refers to those services that in the community, it's the very first ones that people go to for healthcare, whether it be general practice, Aboriginal community controlled health services, community pharmacies, allied health, mental health services, drug and alcohol services, community health, community nursing, maternal and child health services, sexual health services, and oral and dental services. So there's a whole group that can be brought under primary care umbrella. So when you're looking at primary care, why does primary care matter? And I know that, yes, we are looking at, mental health workforce in the Pacific and that, but I feel that if we do not get the primary health care part of it correct as well, then it's very difficult to make pathways or headways into what's happening in and around the region. So why does it matter? It's because countries with very strong primary healthcare systems are more adaptable, more flexible, and better able to respond to rapid economic and technological challenges, COVID-19 being one of those, and I will touch on that as well. It is essential, primary care, to universal health coverage and focusing on the wider determinants of health, which are crucial to actually improving health outcomes. And so effective primary care really in the long term can improve health outcomes at a lower cost compared to hospital and secondary care. And it does help avoid unnecessary hospitalizations. And so countries with strong primary healthcare systems have definitely better health outcomes as per OECD data and WHO. So when in Australia, there was a 10-year plan for primary health care, 2022 to 2032. Some of the key messages in the consultation process, and these are themes, I'm just going to touch on a little bit here, because we can't just talk about workforce on its own. There's a whole lot of other areas that need to be addressed together with the workforce. And so in terms of that, the themes that basically came across were access to appropriate care. For example, there's a lot of people living in rural and remote communities here, even in Australia, that have limited access to health care services and poorer health outcomes compared to those living in metropolitan areas. Another example is Aboriginal and Torres Strait Islander people still have overall less equitable access to appropriate and culturally safe care. And significantly still poor health outcomes than other Australians. Then we look at the CULT communities. So CULT communities are the culturally and linguistically diverse communities, and us Pacific people are definitely part of the CULT communities here. We still face, language, cultural barriers and that to access and healthcare as well. People with disabilities have same issues as well. They face high levels of chronic disease and preventable diseases, and they die younger than the average Australian. People with mental health issues definitely face a lot of barriers, as already alluded to by Sir Colin. It's not just here in Australia, it's in New Zealand, it's in the Pacific. Same barriers that we see. Then we look at the integrated person-centered care. So the Australian health system can be a little bit difficult to navigate, especially for parents of young children, older Australians and their carers, those with chronic complex conditions, people with disability and their carers, as I mentioned before, people from CULT backgrounds, the LGBTIQ plus people, and people in socioeconomically disadvantaged circumstances. And, the other thing that people complain about is that they have to tell and retell their stories whenever they go to their, GP or the nurse navigators or the mental health workers that they are in contact with. And that to them is associated with, burden of time and effort and frustration on their behalf, which is totally understandable. Then you look at the funding models. So funding models definitely, here in Australia, we have the MBBS system, which tends to reward the volume of services provided over the value or quality of care. And I know that there is effort concentrated on trying to move away from this in terms of volume care, but base it on a value care system. Now we come to workforce. So workforce definitely is a challenge. And I think it's a challenge in every single country and community. I'm just going to have a look. Sorry, here. So even in Australia, we still struggle with workforce. And this is not just in primary care, it's also across the nursing sector, across mental health sector, across every single sector associated with health. And this is because there are barriers everywhere. And, some of these barriers are, for example, in the medical world, medical students need to be encouraged a bit more to choose general practice as a profession. A lot of them are going away from general practice because it's too hard. Two, they prefer to be in the public system, in the hospitals, because then secondary care obviously have higher incentives and better remuneration than being out in general practice land. There is the problem of access to a range of healthcare, professionals. Again, even though there is a lot of allied health around, pharmacists, we have a whole range of different allied health support out there, but there's still not enough in terms of access compared to the population. So I work in Brisbane, actually in Beenleigh, which is one of the lowest socioeconomic areas here, and I have a lot of Pacific Island patients. Being Samoan and speaking the language, I tend to see a lot more of my own people here. And it can take 6 or 8 weeks to get into me. It's very difficult to get into me. And that's because language, is very important to our people. And not just that, we have very few Pacific Island nurses, even within our own community, in our own clinics. So again, accessing nurses and even our mental health workers is just not enough here. So when you look at the other things or the challenges in terms of primary care and that in terms of the workforce, basically, most of them are not working to their full scope of practice as part of multidisciplinary teams, because that is the thing that's being here. We have things called healthcare plans or EPCs, where if you see somebody with a chronic disease, you then can access your allied health at reduced cost or funded by Medicare, so that you can go and see, for example, somebody with diabetes, you can go and see a podiatrist, you can see a diabetic educator as part of the team, you can see physiotherapist and all that, and you can see your endocrinologist as well. So it's all part of the surrounding the patient with the appropriate care. And then, of course, there is the question of that the workforce, as you all know now, I mean, it's universal. There's a shortage universally of the workforce. And it is very much here in Australia, it is mal-distributed in terms of shortages of nurses, and especially in the rural and remote areas. And I know that there's been different programs that the College of GPs has been trying to initiate over the last few years to try and attract more registrars and that to go into the rural areas. And there's been, some success, but at the same time, there's also the ongoing challenge there. So in terms of, how, or I guess opportunities and that, we look at things like, there's so many different models here in Australia for access to healthcare, aged care, disability systems, and that. I guess one of the key things that came through on that 10-year plan for Australia itself is trying to harmonise all those funding models, so that then therefore you can optimise the allocation of your nurses and your workforce. And definitely leadership and cultural shifts are needed as well to support the team-based environment that we're trying to look towards, which then also supports the broader healthcare system, and it supports the profession as well, so that people can work to their full scope and maintain high quality. So I guess the future focus, as the pandemic definitely showed, here in Australia, we depend a lot on telehealth. So telehealth, patients couldn't come to the clinic, so we had to do telephone consultations with them so that we can still keep in touch with them. Definitely to try and obviously it's not the same as face-to-face consultations, but it is something that's been adopted by the Medicare system here, so that it continues at the moment to allow people who are in rural and remote areas to be able to dial into their doctors, even for prescription and that. There is the ongoing thing as well of video linkage as well, so that, you can see the patients. I know there's work going on in the Northern Territory at the moment that nurses can go out and can do baseline observations from there and then send it through by video link to the clinicians up there, and then they can prescribe medications and that. So ongoing, the quality of telehealth and virtual health is definitely there, and that's definitely one of the innovations that Australia is very, very at the forefront of, to try and continue to support primary care in rural and remote areas. And even then, again, still, as you've heard already, there is always a lot of research that's needed across all provider groups. And research that's not just for research's sake, but research that then allows us to have some tangible plans to improve outcomes across the whole of the sector. So, you know, as already mentioned, and that this is about the best practice health systems, the challenges are there. These are the challenges that we face here, which, as I said, it's probably, and I'm just suspecting, is actually very similar across the region as well. And definitely at the moment, I mean, we're seeing increased rates of chronic diseases along the mental health side of things during COVID. And as you already mentioned, I mean, as Dr. Colin already spoke to, mental health was a major issue here in Australia too. A lot of anxiety, a lot of depression. And it was good that we had telehealth so that we can at least communicate directly with our patients, and also allowed our mental health workers to actually communicate and provide counseling and support to all those who are in rural and remote areas. And that's it for me. That's it. Sorry, Michelle, can't hear you. Yeah.
No, I could hear my voice had gone somewhere and I couldn't work out where it had gone. I'm back. Thank you so much. That was a really good overview, and I think you're right. The challenges between across Australia are reasonably significant, and certainly lovely to have your perspectives from a Samoan background as well. It was a really lovely presentation. Thank you for that. And I'm hoping everyone's building up their questions for Natalie. I know Natalie's been streaming through the chats to find questions. And this is really the most important session in a way, because this is where we want your opinions of what we need to do going forward. I know there are quite a lot of studies out there and there's some proposed work, but I think if we could get some comments, and if you haven't put some chat in there and would like to raise your hand, I'm sure if we can, Natalie can navigate that. We still have our 3 speakers online. So just really to introduce you, Natalie. Dr. Natalie Cutler's from a senior lecturer with us at University of Technology, Sydney, and certainly has an extensive body of work in this area around mental health psychiatry, and is in the School of Nursing and Faculty of Health. So over to you, Natalie.
Thanks very much, Michelle, and it's a great privilege to be here and hear all of the presentations. So profound. It's going to take a while to process so many of the important pieces of information that have come forward today. So there have been some questions coming through in the chat, and I might start with a question from Asita for now about how do you deal with mental health issues from our ethnic specific patients that see you as a Samoan GP. So that would be a question for our last speaker, Kunaliti, if you wouldn't mind answering about how you deal with mental health issues for specific people.
Yeah, thank you, Malo Lule Eseta, and everybody. So yeah, thank you for the question. So yes, at general practice level, we do see a lot of mental health issues. And as Sir Colin already alluded to, there's a lot of stigma still associated with our young Pacific people coming in to see us with regards to mental health issues. So when I see, and I've been seeing a lot of the younger generation coming in, as well as, so say from 18 up to say mid-30s, coming in with anxiety, depression, suicidal ideation and all this. If it's really, really acute, I have access to the crisis team at the hospitals that I can contact, that I send people to. Beenleigh is in the Logan area, which is the highest concentration of Pacific Islanders here in Southeast Queensland. We have access to a mental health team as well that I can call upon if it's really acute. Now, when I say acute, it means that they're frankly suicidal. No matter what I say or I do, they are just not going to, they still have the intention to suicide. Then they go to the crisis team or to the mental health team. if it's fairly mild in terms of it's just started in terms of anxiety or depression, I just spend the time with them, have a long conversation, because then I bring up all the challenges that you've already heard about from our speaker from Samoa, in terms of the pressures and the challenges that our young population have to deal with in terms of being forced onto the workforce to support the families when they want to have their own dreams and that. And as we explore these topics and that, and we talk about, how else we can have a discussion, I normally ask them, look, I'm happy to invite, your parents in so that we can have a discussion, because this is the thing about language, that we are able to actually cross over into our own cultural way of, dealing with these problems. And that often helps them as well. When it comes to other conditions, for example, schizophrenia and that, and again, I do have quite a few patients with this, and it is, as you probably are all aware, it is related to use and abuse of, often habitual drugs in a young age, which then alters their brain waves and all that sort of stuff. But it's not just that. It's also about environment. It's also about their belief systems. When it's that, then I, again, seek access, help from my mental health team that are just a phone call away. I don't know whether that answers the question, Eseta.
Thank you. That was very comprehensive. I do have a couple of other questions here that are really very pertinent. So the first question is from Nick Murray, and this is about what types of services are there for mental health and wellness in the islands? Are there mobile units? Do patients travel, or do the clinicians travel to provide support, evaluations and care? And there was a reference to nursing stations. This is obviously a question for Millie. Nurses stations, are those on non-hospital islands? And generally curious about wellness access. So if anyone has any information about what sorts of services are there for wellness, particularly in the islands, whether services travel to people or people have to travel to the services.
Maybe Dr. Natalie, I can respond from Fiji in terms of the services that we provide from the nursing station or the maritime, and also in the main land. We do have nurses that they look after the nursing station, and also have nurses and medical officers in the health centers. They do have programs like MCH clinic for wellness program, visiting domiciliary cases in terms of the NCD. They do go out and have a school visit, go to the community for the MCH. It's the accessibility is being taken. And sometimes the public do comes into the nursing station, or the public to the health center, and there is a identified date, like which village that's supposed to be coming to the clinic. So if there is in the absence of the nurses or the doctors, they are going to put out the notification. They will be out visiting. They can see maybe the community health workers or the village health workers. Yeah, those are some of the things. They also participate in terms of the school. They work together with the school when there is a wellness program, whether it's heart, mental health, or substance abuse, either NCD and CD. Yeah, that's the current in terms of the primary health care in Fiji.
Thank you. Thank you very, very much. I'll keep moving with the questions just so that we can have as many as we can possibly fit in. So there is a question from Gordon, which is a little bit linked to the previous question, but specific to the well-being of nurses in the workplace. So again, Millie Carey, I think that you're possibly going to be best placed to answer this, but there may be answers from others as well. So the question is about what strategies are being put in place to support the psychological well-being of nurses in the workplace.
That's a very interesting question, Madam Natalie, because speaking from, I will just have to speak from the mental health services in relation to my nursing workforce at St. John's. One of the things that in terms of the psychological, what I'm trying my best to do is to support my nursing colleagues, nursing staff in terms of self-care. That is number one. They've been asking to go to have self-care in a hotel or even in some of the, away from the requested for this shift. Those are some of the things that I've allowed and supported them. They need to go in groups. We do have celebration, like celebration in terms of promotion, celebration in terms of, achievement, birthdays. Those are some of the little things we would like to value. In terms of the clinical practice, when we have a burnout or even incident, I always encourage, because I will not be there in the clinical most of the time or will be with them. The only thing is that, advice them to have debriefing, but this needs to be strengthened. We need to have more in service. So because of the burnout that has been happening, even sharing with them the way that, during your pay, I always share with some of my staff, buy something for you, treat yourself. Before you treat other people, treat yourself. So that, what you have, work hard, you enjoy, and then maybe then you can take it home or with obligation. As a Pacific people, we've got obligation. And this is some of the things I always share to my staff. Please buy something, enjoy, that is for you. And then you can have the obligation maybe later. Those are some of the things, but I do not force them, but just share with them, because of the challenges that we are facing and the trying times that we are now. Yeah. Currently, for the latest one, the St. John's Board of Visitors are working on, we are going to take out maybe a treat for the hospital staff to take us out, divide up into 2 groups so that we can enjoy ourselves, and also training on how to handle aggressive client. So they're going to support the people who's going to do the training. Maybe this is one of the platform. We are asking if someone can help us, like maybe in Australia or New Zealand. We would like to have the how to handle aggressive client. If someone can help us in terms of, but we'll try to get the course and all those things. Yeah. So maybe I give that answer. Yeah.
Natalie, can I just add to that?
Yes.
Certainly just from the South Pacific Chief Nursing and Midwifery Officer Alliance, I just wanted to add that across the Pacific, it's so incredibly diverse. For those who aren't aware of the diversity, I mean, there's between 22 and 26 different island states coordinated by either France, America, individual sovereignty. It's a very complex, and we know from research we've done in the Pacific that there are huge gaps, especially around psychosocial skills training, and it often falls through the gaps of both health, Red Cross and education. So I think although we're very aware of these issues, I think the complexity and diversity, and even Papua New Guinea is often included in the Pacific, and that's got a population of 10 million versus Cook Islands with 11,000 population, or Vanuatu that has 300 islands and only 90 of those are populated. It's just so complex, and we have to be really careful when we're talking about the Pacific that we're not just talking about one island, and Aseta clearly highlighted that. So I just thought for some of those online who aren't aware of the complexities, I'd just add that. Thank you.
Thanks, Michelle. Really important point. Thank you. And again, I'll keep moving through the questions. Some of them may not be able to be answered in this forum, but they are worthy of proposing for reflection and consideration. So a question from Peter is that, are there any examples of effective family and community-led mental health initiatives that have arisen as a result of inadequate mental health workforce or poor access to care? And could these be replicated to supplement mental health care elsewhere? So the last part of that question might be taken on notice. But if anyone, any of our presenters is aware of any examples of family and community-led initiatives, not necessarily because of problems with workforce, but just generally because it can be a very effective model, you're welcome to share. So I'll just take a pause, and if an answer comes up later, we can go back to it. Jenny has asked, how do Pacific Islands mental health services leaders reconcile the illegality of homosexuality and suicide, especially with youth? Again, if anyone has any response to that, it might be a reflective question.
I wondered if Jessie was able to speak to any of these youth issues. I know she's not a health practitioner, but might have a perspective that we haven't covered.
Mm-hmm.
Jasmine, sorry. Jasmine.
Yeah.
Yes, thank you. So I was just looking at that question a few minutes ago. It's great that it's come up. I can only speak for Samoa because that's the current scope of my work as an educator. Presently, we are struggling to reconcile that. Samoa is a constitutionally Christian country. We do have a very big and quite widely accepted female transgender community on island. However, specifically looking at mental health in young people as it pertains to sexual orientation as well as gender diversity. Currently in Samoa, we're very much struggling with that. One thing that I did find out recently, because I had an experience in my work as an educator, is that quite a few of the young males, as they are identified by the statistics, actually identify as transgender or fa'afafine, and the suicide rates among them are increasing in our country. So what this does tell me is that in terms of reconciling, providing mental health care that is specific to the very unique issues that are faced by these particular communities in our little island state, it's very difficult at the moment. The main centers, I would say, for help that young people can go to are things like the church, the youth groups, the sports clubs. But even in these spaces, I quite willingly admit that things like homophobia and transphobia are still very rampant. And because this is an issue with the mentalities, it is something that not only is quite deep rooted, but I think will take quite a long. How do we reconcile it? There's different. There are people who are willing to talk to youth, but it just depends, I think, on who you choose to talk to. Someone was saying to me the other day, as a matter of luck, you might ask for help from someone who will help you. Quite often, you ask the wrong person, and they'll give you a telling off. So that's where Samoa specifically is at the moment. I'm not sure if my colleagues in other parts.
Thank you, Jasmine. Okay, so we are almost out of time, so there might be time for perhaps one more question if anybody would like to post. Okay. Thank you. Thanks, Michelle, for providing that information. That's an excellent resource, free resource, and that's available in the chat. Now, before we close, this is from Ernest Mensch. Okay, yes, I'll leave that with Julie. Okay, so I might finish with this question from Gordon, which is thanking everyone for the answers to the questions, and particularly well answered on wellbeing. Given the complexities of the work, I hope that you'll continue to build, just a statement, I hope you'll continue to build on access to psychological and or therapeutic support for nurses in Fiji. All right, thank you. I think that's a very nice note to finish on and hand over to Julie, because amazingly for such a forum, we're running right on time. So Julie, shall I hand back to you now? Thank you everyone for your questions.
No, I'd like to hand it over to Michelle, who does the wrap up. Thank you, Michelle.
Okay. Sorry,
Right.
Michelle.
Oh, good. Thank you. And Julie, be ready. There might be some things. Now, just really to thank everyone enormously for this really, really important webinar. And I think we'd all agree that our hearts and minds are with our Pacific colleagues, especially with the health workforce crisis. And Millie spoke about it very clearly, but just to be really clear, at the moment, Fiji has lost a third of its nursing workforce. So all of these issues are complicated and complex because of the health workforce crisis we have in the region. We know WHO have agreed to do a regional study, so we hope that will come forward very soon to look at some of the migration issues. There's also some other work supported by the Australian Nursing and Midwifery Accreditation Council looking at sort of quality improvement of nurses in the region, and not directly related to mental health, but I think we need to look at the baseline. I've also been sharing some resources in the chat around some free basic psychosocial skills training, and other people have been sharing really good resources, so please look at those. Also, WHO has just released its regional framework for the future of mental health in the Western Pacific, and that will be shared at a regional meeting that Sir Colin and I will be attending in a couple of weeks. And that will give a mandate for the Pacific and the region to feed back on mental health issues. And I think that's really important, because that will enable us to have a role to feed back. And so I guess finally, from my point of view, I hope these webinars, you're finding them useful, and how we go forward. I know Julie is really keen that we have a face-to-face in 2025, and I think that sounds really logical, in line with the fact that some of the research will be out and about then from Colin's work that we can present. I mean, does that sound reasonable? Would everyone like to put up a hands up, or a sort of a tick to that, and we'll work towards that? I'm just looking at some of the many comments there, and there's the register for the Creating Futures org.au online, which is coming up in a couple of weeks, which is another opportunity. Thank you. That's great for the thumbs up, everyone. I think we really just need to keep moving forward. Areas that came up around funding models, a real need for leadership, dealing with the health workforce crisis, and really the lack of data that we've had on mental health in the region, but it does feel like there's a bit of momentum with some work going on at the moment. That's about all I've got to say, apart from thanking everybody, including our speakers, our participants. And Julie, just over to you to say a final thank you.
Yes, absolutely. I have to say this has been probably one of the best webinars I've attended, and you can imagine I've attended quite a few, but this has been absolutely brilliant. I would really love to thank Colin and Millie and Jasmine and Kunileti for their fabulous presentations, and to Mia Kami for her powerful song, which I agree was very moving. But also too, this webinar did not happen without a lot of behind the scenes and on, as you can see, on camera. So like big thank you to Michelle for her moderation, to Natalie for her behind the scenes, and also for her Q&A session, to Kelsey, who's been managing the technological aspects of the whole webinar, but also to all the members of the Oceania Mental Health Advisory Committee, and to the webinar working group. We've had a lot of work happen over the last few months to get it to this point, and look how fantastic it has been. Thank you to everyone. I also want to thank everybody who's attended today and for all of your fabulous comments in the chat box, and for your great questions as well. So thank you, everybody. I hope you travel well and safely, and that your family and friends remain safe and well as well. Thank you. We are 2 minutes early. That is most amazing.
Well done, everyone. Thank you.
Bye-bye.
Thank you.
Bye-bye.
Bye.